Okay, well, first of all, thanks for having me, and hats off to Alice. It's one thing to throw some money in for a good cause, but it's another thing to invest so much time and effort into it and get a group of blokes into the same room, which is a pretty hard thing to do when we start talking health. I suppose, contrary to the other couple talks that we spoke about before, mine's probably a little bit broader. There's lots of different types of joint injuries and bits and pieces that can go on. I'm sure, and it's probably, I don't think too many people in this room would have been immune from one at some point in their life. I know I've done my fair share. And of course, we've got a very broad audience here as well. We'll be covering a fairly broad overview of joints. Okay, please feel free to ask any questions as we go. Billy's nicked off, so I was counting on a couple questions there. Yeah, feel free to throw some questions out. Okay, so basically the joints, what are they? There's three different types. There's those joints that are fused together, so like your cranial joints that fuse together early in life. They're the fibrous joints. The next type of joints are your cartilaginous joints. They allow a little bit of movement, so that might be around your sternum, at the front of your pelvis, down through your discs in your spine, where it's a piece of cartilage that is connecting two bones together. I'm sure we've all done some damage to those before too. And then the third and the most plentiful type of joint in the body is your synovial joint. So that's the ones that you guys would be most familiar with. They're the freely mobile joints, so the ones in your hands, knees, ankles, hips, shoulders, and right throughout your body. Okay, and they've all got some common characteristics. And so, for example, you've got your synovial cavity. Now, that's the gap between the bones, okay, where all the fluid and the other bits and pieces sit. You've got your joint capsule. That's like a Woolies bag that wraps around the joint to keep the fluid in, a milky fluid. It's a bit like whisked egg whites. And it's quite a milky fluid that provides lubrication to the joint, but it also provides the nutrition to the joint, and there's also factors in that fluid that clean your joint too, okay? And there's kind of two layers to it. There's the outer layer that has all the ligaments wrapped into it, so it's kind of like a structural layer, and then there's the inner layer that actually helps release some of that fluid, okay, that controls the release of it. Then you've got the articular cartilage. Now this one gets all the airtime, doesn't it? You know, we all know about arthritis, and there's lots of different things you can do to that. But that's obviously the smooth surface, which reduces the friction of the joint when you're moving it, okay? Now the other bits and bobs that you've got in there, most of them have some or all of these. You've got the cartilage discs or menisci. Now if I weren't holding this, I'd be able to show you a little bit better. But the menisci is the blue thing in between the knee here, okay? That's the cartilage disc in between the knee, okay? And you might have already had a meniscal tear in your knee or know someone who's had one, especially those people who play those land and pivot type sports. And basically they have a couple functions. One is as a shock absorber, and the second thing is, much like in the knee, these little blue things are like egg cups, okay? So they hold the rounded part of the bottom joint in congruent with the joint below, okay? Then we've got fat pads. Now that's kind of like the cushioning around the joint. Their only real function is to reduce shock to the joint. For example, if you were to kneel on your knee or take some trauma. Tendons and ligaments. Now does anyone know what the difference between a tendon and a ligament is? Or brave enough to actually say it? No? Well, your tendons attach to your muscles, okay? That's the way that your muscles attach to bones, okay? And ligaments attach bone to bone. So your ACL in your knee, for example, would be a ligament because it's attaching bone to bone, whereas your hamstring tendon would be the thing attaching the muscle belly of the hamstring to the bone, okay? And you can obviously get injuries to both, and we'll go through that in a little bit. Bursa. Anyone heard of bursitis? It must be the Oscars. Bursa, they're fluid-filled sacs. They're a bit like a ball bearing, really, although they're not as hard, that acts to reduce friction between tendon and bone. So, for example, Your patella tendon here has a bursa underneath it to prevent the patella tendon rubbing against the bone underneath, okay? And many of you may have heard of hip bursitis. That's where some of your hip muscles, where your hip muscles are separated from your ilium of your hip by this bursa to try and reduce friction, okay? Then we've got the synovial fluid. Now this is good stuff, okay? This is the fluid in the joint that to a large extent controls the health of the joint, okay? And like I said before, that controls the nutrition within the joint, controls some of the shock absorption within the joint, and it controls the cleanup of the joint. Okay, I just wanted to throw this one in there because there's a real sacrifice in some of the joints between mobility and stability, okay? So anyone know what this one would be a x-ray of on the right there, or my right? That is your shoulder. And you'll notice that this rather large ball sits on a very shallow plate. That's meant to be a cup. It's a ball and socket joint. So in this situation with your shoulder, you're relying on a lot of ligaments, muscles, etc., to maintain the stability of that joint. Okay, and that's why we have a lot more injuries in the shoulder than what we do in this one. Does anyone know what this might be? That is a hip. Okay, you can see it's a much deeper socket. And a much deeper ball and socket joint. So you've got a lot more stability there, but of course you can't move your hip as well as you can your shoulder, okay? So this one has got a lot more anatomical sort of stability, and the other one relies on some of the structures around it that we said about before. Okay, what can go wrong? Well, a fair bit, and I'm sure we've all experienced it to some extent. So I'm just going to go through some broad obviously we're trying to serve the masses here a little bit, but I'll go through some broad things that can go wrong in these areas, and then next we'll talk about what you can actually do about it, okay? So with the articular cartilage, the most common one we would know about is arthritis, okay? Now there are hundreds of different forms of arthritis. Some are due to wear and tear over time. I'm sure we've got some footy and players in the group, and cricket players with that landing foot. And so you can get over time some wearing down of those surfaces. But there's also forms of arthritis where the body, like autoimmune type arthritises, that actually get the wrong idea and start attacking the joint. Okay, so your cells start to turn on themselves. So there's different treatments depending on what type of arthritis, and I won't have the time to go through even one spec of the type of arthritis tonight. The other thing that you can do in young people, you can actually get some peeling of the cartilage off the bone, okay? It's got a really long name, and you will see that sometimes in young people, okay? And you'll get catches of the joint when that's the case. Fractures, there's lots of different types of fracture, but in concerning joints, there's probably two main types that you need to know about. One that actually goes through the articular cartilage and can cause some issues going later on, and some that are either below or above the joint line, which do tend to heal really quite well with a pin or conservative management. Ligament tears. Who in this room has done their ACL or their PCL in their knee? Normally there's a couple. 1, 2, 3, 4, 5. We'd be interested to know, and I was going to save this for the next bit, but recent studies have shown that 58% of people, 58% of ACL injuries will spontaneously heal when they've had an MRI after 5 years now. So there's a different tact in how we deal with ACL injuries these days, because we know now that they have the capacity to heal rather than jumping in on them straight away. Okay, so if you are Roden playing for the Crows, who had that Lars surgery, yes, you're probably going to get the operation straight away, so you can jump back straight into sport. But if you jump off the back of the ute and you hurt your knee, you do now have the option of going the conservative route. My brother did exactly that. So ligament tears, tendon tears, so that is, you would have heard of those, grade 1 through to 3 of either the muscle or the tendon that attaches to the bone. Normally when we're talking about ligaments and tendons, grade 1s are a slight tear of the tendon or the ligament. That might be a 2 to 4 week injury, not a lot of loss of function. You can play through them with sport with some taping if it's grand final day. Then you've got your grade 2s. Your grade 2s are fairly significant tear. It can be right up to 95% tear of the joint, where you've got very significant loss of function of the tendon, and you'll be looking at somewhere between a 4 and 12 week recovery time, depending on how much you've gone through it and what tendon it is or ligament it is. And then of course you've got complete rupture. Now, complete rupture once upon a time, like I said before, largely always meant surgery. Now we know that we can, with maybe immobilisation or with some bracing or with time, you don't always have to go the surgical route. Okay, so take some gusto out of that. So infection, generally infection, you can get infective arthritis, but generally infection only occurs once someone has entered the joint, okay? So that would be generally with the orthopaedic surgeries, where they go in with arthroscope, or they've done a total knee replacement. So that is a risk, obviously, of surgery, and another reason why sometimes it's worth considering conservative management first. Cartilage disc or meniscal tears. Quite often that is, for example, if we're talking about the meniscus in the knee, those land and twist type injuries where you might either split off a little tag or what they call split it down in the middle, a bucket handle type tear, where they might either leave it completely if it's nothing significant, they might go in and sew it up, or they might clip it off altogether. Very poor blood supply to the meniscus, so the surgical route doesn't tend to have that greater incidence, so only get it done if you absolutely have to, okay? Tendinopathies, that is where the tendon, so that's where the muscle attaches to the bone, gets very grumpy, okay? And then we'll have to look at the reasoning why that is. Generally, it's because we're using our body in a way that it's not used to working. So for example, if you decided that you wanted to run the City to Bay next week and thought you would do a 5K run tomorrow, your tendons aren't going to be too happy about that. However, if you were to decide to work up to walking 10Ks and then slowly, part run and slowly build that up over the next 3 months, your body would have probably no issues with that, okay? So generally we get tendon injuries when people jump into things a little bit too quickly. And the bursitis is the inflammation of that little bursa that we're talking about before, those fluid-filled sacs that are between the tendon and the bone, okay? So you end up with something called bursitis, and there's a range of treatments we can do to help that as well. So what do we need to know? I've tried to keep this short and sweet and keep as few slides on here as possible. So knowledge is power. What I mean by that is if you understand what's actually going on in your joint and how they work, what things you can do to keep them healthy and what happens if you don't, well then you're more likely to look after them. And you may need some advice if you're currently going through something or if you want to look after your joints going forward. So knowledge is power. Learn about your joint if you are worried about something, and we can help you do that. Graded return to activity, well I've just given the example before, and that's not just the case in individuals that have been doing absolutely nothing and want to jump into something completely new to the body. It's also important for those people that play footy for 8 months of the year, sit down and play video games or drink wine and have cheese for the other 4, and then decide to jump straight back into footy again. That first pre-season, I think most coaches take a lot of joy out of what they can put you through in that first session, but often it's at the detriment to yourself. So graded return, okay? So you need to grade yourself in, and that's the case either when you want to do something new or when you're returning from injury, okay? And again, common sense does a lot of help there, but you can also get help from professionals there too. Now, has anyone heard of RISA on your left of screen there? So that's the rest, ice, compress, elevate sort of thing that have been pushed for ever, okay? That has changed in a big bad way in recent times. This is the new acronym that you have to put up with, love and peace, okay? Now, I'm not sure whether I agree with Sports Medicine Australia on this one, because RICE worked well because people remembered it. And I have trouble remembering what all those letters stand for in love and peace. But just to go through it, this is what is recommended for joints when you're dealing with an injury, okay? So this is really going to put me on the spot, but load, okay? So L stands for load. You're going to have to reduce the load on that joint initially to allow it the opportunity to heal. But that doesn't mean remove load altogether. O is optimism, okay? Now I know it's very fluffy, isn't it? But optimism, there's been lots of research recently around the links between the brain and the amount of pain that you feel and the ability for you to get back to sport and how your brain impacts those healing factors around your joints. And so we do see a lot of people that come in now with Dr. Google that come in feeling quite catastrophic about their injury, and it does actually impact your heal time, believe it or not, okay? So quite often it helps to be optimistic and know that almost all tissues in the body will heal if you give it the opportunity to do so. V stands for vascularisation, okay? Vascularisation means if for example a knee injury, get on your bike, okay? Get on your stationary bike. Vascularisation means do some aerobic exercise to start getting the blood flow back again, okay? E stands for elevation. There actually is, the reason why RISA is now love and peace to some extent is because there is zero evidence for ice, out there now, zero evidence. It's thought that what it actually does is halts one of the body's natural processes. There is a reason why inflammation gets sent to the joint, and there is a reason why the body has to go through that process to both protect the joint, get rid of some of the nasties that are like the debris around the joint, and then start the healing process. So when we start using anti-inflammatories and using cold packs, we actually halt the healing of the joint, believe it or not, okay? So ice, no evidence for it, unless you're using it for pain management. I've always found it makes it more painful, to be honest. And E, elevation, not much evidence for elevation either, but it can help deal with the severe fluid that you can get in some of those joints, okay? And of course, if you're elevating, ideally you're elevating above the heart, okay? How can you do that with something in the lower limb? You recline or lay back, okay? Peace. P. I'm just trying to think what that is. Protection, okay? Protection. So that is, for example, you wouldn't head back into a trauma-based sport. You would you may need a bracing or taping in place to support it. E, where are we at with this? I'm trying to remember what they are now. This is a relatively new acronym. Yes, please do.
Educate.
Educate, okay, so of course people need to know about their joint. A, what are we at with A there?
Alcohol.
Yes, that one is not overly helpful. Anti-inflammatories is A. Anti-inflammatories. So it's thought that anti-inflammatories actually impact the healing process as well. So now they are not necessarily recommended because they halt the normal healing process. Where are we at with C, Mads? Compress, okay. Now compression, again, there's very little evidence for compression, but a lot of people find it comforting to have it in place and it doesn't do any harm, okay. So some of these things still remain in there, for example, elevation and compression, because they do no harm and they might help with your painful symptoms. And E, believe it or not, is exercise, okay. So it is, so if you take us, a couple thousand years ago, we didn't have the opportunity to sit down and be waited on and have a ready access to food. We unfortunately, when we rolled our ankle, had to get up and keep moving, and the body has adapted to be able to do that. So you'll notice after joint surgeries, for example, they would have had you up very early on after the surgery itself. And it's the same thing for an ankle, knee, hip injury. They'll get you up and moving really quickly. We were talking about that synovial fluid in between before. That, if we're not regularly splashing that around the inside of the joint, you're not getting nutrition to the inside of the joint, okay? So it's actually really important to get that vascularisation, that movement, and that exercise in relatively quick. Now, you probably may need some advice depending on the injury that you've done as to how quickly to do that. I'm not saying to jump straight back on the bike and hit the trails the day after, tearing your ACL, okay? But yes, that's what's recommended. Exercise versus surgery. there was an orthopaedic surgeon who had to have a knee replacement. He didn't want one. He'd done them on lots of other people and knew what sort of garden tools were used in that process. And don't get me wrong, there are definitely places for orthopaedic surgeries. But they then did a study of an exercise intervention compared to the orthopaedic surgery and found about the same result. Now, what the main findings of the study were is that it's worthwhile going through a conservative management treatment first, and then the ones that don't respond well to that, providing that you stick to it, can then move on to the surgery afterwards, okay? So don't be so quick to go under the knife. You may not have to, okay? Static versus dynamic warm-up. Now, the static exercises, for example, are the stretches like this. Again, almost no evidence for static stretches, okay? We've done them all our life, and this evidence has been in place for 10, 15 years. We're just starting to catch up on it now. The only time it has a place is, for example, if you've had a joint immobile for a long period of time and you need to get the range of movement back again. But as for before sport, what they really recommend is the dynamic warm-up. And we're doing that as well, to be fair. So that's your run-throughs, that's your small kicks, that's your side steps, walking backwards, all of those sorts of bits and pieces that you're mimicking basically what you're going to do in that sport. And if you're thinking about what is an effective warm-up for sport, you don't need to be a physio to work that out. You just need to break down what you're actually going to need to do within that sport itself, and do those movements prior to ready the muscle for that event, okay? To brace or not to brace, quite often we get asked about taping and bracing with any number of injuries, whether it be arthritis or an acute injury. Taping and bracing is really good for the return back to activity. For example, the taping of the ankle after you've rolled it when you're wanting to get back to sport. However, if you're taping at all wakeful hours or bracing at all wakeful hours, it actually has the opposite impact, because you're doing some of the job of the ligaments, tendons, muscles for it. And so if you ever were to remove that brace, your knee or hip or whatever brace you're using would actually be in a worse position than prior, okay? So they are great for weaning back to activity, but we wouldn't often recommend that you wear them at all times unless you've tried everything else and it's the only way to stabilise the joint without surgery, okay? The pain sciences, we kind of touched on them before. I won't go into too much detail, but basically we used to think that pain was an output. You know, you poke a pin there and it causes pain. Well, now we know that what actually happens is when you poke a pin there, it sends a message to the brain and the brain decides whether to release pain or not, okay? That's why your kids, for example, they won't cry until they see the blood, okay? And the reason why is because we know that there's a lot of different centres in the brain that play into that pain experience. So previous experience, for example, does. That's why when I drive past the dentist, I get a little bit of a fuzzy tooth. Or when you see a man get hit in the groin with a ball, you get that little bit of a feeling, because previous experience tells you your brain has seen that threat and it's responding to an extent. So I guess what I'm saying is that if, for example, you've been told that you've got chalky bones or you're full of arthritis, that's going to increase your threat level and make you less likely to move and will actually increase your pain, okay, by having that threat associated with it. Motion is lotion. I might actually show you this for a moment. You don't actually need to be able to read it, but this line in the middle here, these are all studies that were done over a 20-year period. This line in the middle, over that side, was an exercise intervention. This is for people with arthritis, by the way. On that side was the exercise intervention, and on this side was rest. So in all situations, exercise made arthritis better. And in what ways? The ways that we're talking about over here: pain, reduced medication, walking speeds, quality of life. Now, these happen to be the results of a program that's being run in Australia at the moment. I'm not sure whether you've heard of the GLAD program. Anyone in the room heard of it? This is something that specialists are starting to go to prior to doing orthopaedic surgeries on hips, knees and ankles in particular. This program is a 6-week-long program with a couple hours of education in there so that you can learn about your joint. They take measurements. The first week you come in, 3 months and 12 months. All of your data is uploaded into a system. So this is out of tens of thousands of people in Australia, this data. And what they found is that this program for 6 weeks, although they do give you some exercises to continue on with if you'd like, reduced pain by 33% in the knee, 27% in the hip. It reduced medication usage by between 40 and 50%. It reduced walking speed, increased walking speed and quality of life. These two are factors for the older individuals that are sometimes involved in the program. But in general, this is from a 6-week program. So you can see that there are, a lot of people think that why try the conservative management? It doesn't actually work, but it can actually work reasonably quickly so long as it's targeted, okay? I'll just go back for one moment. Motion is lotion, that's what we were talking about before. You want to keep readily changing the fluid within the knee joint and move it or lose it. Now everybody's heard this saying, but what does it actually mean and what are the numbers? If I were to put a cast on your ankle, you would lose muscle mass, at least initially for the first week, at 7% per day, okay? That's big, okay? Not actually, you don't normally lose the strands themselves, but the strands reduce in size by that amount. And of course, that very quickly reduces, that pace won't keep up, otherwise you'll have no muscle there once you take it off. But as soon as you immobilise a joint, the body is really fantastic at adapting in both directions. So for example, if you did want to do that city to bay run, it's great at adapting and improving your ability to be able to do that, but it also does the reverse. If you don't use something, it also doesn't want to feed it, okay? So if you're not using your bum muscles when you're running around, you'll end up with a flat bum because the body doesn't want to fuel areas of the body, muscular areas of the body that it's not using, okay? So you literally will lose it if you don't use it, okay? Very good. Now, I just want to, before we dive into questions, I also wanted to show you this. So this is released by Return to Work SA. So this is well, everybody would know who this mob are, but basically they insure our workers. So this is spinal imaging in asymptomatic patients. Now what asymptomatic means is that people that have no symptoms, okay? So that's, if for example, if we had 100 people in this room, none of us had symptoms at all, and we took scans of all of our back, this is what you would find, okay, on your scans. So I guess what it means is that even though some of these things might show up on your scans, it doesn't necessarily mean disability or pain, okay? So I'm putting this out there to reduce the threat level of some of these things. I'm 35. So at 35, 52% of us have disc degeneration, and this study was 1,100 people, so they took a lot of scans here. Probably, I don't know how ethical it would be these days. Disc bulges, that one gets a lot of airtime. 40% of people my age have a disc bulge. Okay, so there's a pretty good chance I've got one. Disc protrusions or facet degeneration. You know, in fact, as you start to get up to 50 or 60, it's rarer not to have these things, okay? So it's handy to know that these things are a normal part of the ageing process, and that even though you have these things, it doesn't need to equal pain. It doesn't mean they can't cause pain, but it doesn't mean that they need to equal pain. So if you get a scan and you see 5 different things going on, please remember that it doesn't have to equal pain, okay? And that it is possible to live with these things without pain or disability. All right, any questions? Now, first things first, I'm very mindful that instead of talking specifically about one condition where we could have gone quite in depth, we've tried to cover quite a wide array there. So if there's any specific questions, more than happy to try and answer them for you.
When you're talking about the dynamic warm-up, I'm a shearer in that there, and I only do like the little bend over and all that there.
Yeah, so as in warming up.
Going for a run or?
No, you're better off doing things that are functional to what you're about to do, Okay, so mimicking what you're about to do. So it would be, probably doing some of this, and it probably would be doing if ideal situation, you might have some of that stretchy band, and you can start doing some exercises with your arm prior to get it used to what it's about to do. Yeah. Now, in your situation, you'd be doing that 10 hours a day, 5.5 days a week. Your body is so damn good at it now that warm-up probably isn't as important as someone going out on a weekend and playing 90 minutes of sport in the cold in winter, because your body is super duper altered and adapted for doing that, okay? Yeah. So I would say in that setting, warm-up would be helpful, but you would already be very good. Your body would already be very well set up to do it. So prior to that, it might be without the sheep, just going through some of the movements that you would do, maybe 20 of those, just to get the body used to doing it. And any sort of just, like you said, going for a quick run or getting on the cycle bike where you're going to vascularise everything and getting it moving is also a great idea. Yeah. So, yeah. Anything else?
Yeah, if you've got joints that are grinding, cooking, all that kind of stuff, anything, just day-to-day sort of stuff, anything you should be doing for that, like any of those supplements, fish oils, anything like that, actually useful, or...
Supplements is an interesting question, and I know we've got some doctors in the house tonight, and I think that what you do need to be very careful of is that you're not doing any harm initially, okay? So, for example, fish oil, you can buy it on every shelf and every chemist, but it has a blood thinning impact. So you actually need to be really careful. Some people might need to be careful in actually in taking that. It might be good for others. So just be mindful that if you are going to take something, clear it with your doctor first. I know that that's what you see on the back of the pack and you think, meh, it's on everything. But it probably is worthwhile doing that if you're going to take that supplement every day for the rest of your life. I would say, general advice only, with regard to doing no harm, the fish oil and the omega-3s does tend to have the best bang for buck in a few ways. One, there have been studies to show that it helps with the vascularisation of the tissue around the joint, underneath your cartilage. So that's a good thing. And the second thing is it's also got pretty great evidence for your brain and your cardio system as well. So that's a bit of if I were to pick one, that's probably the one I'd go with, and I take that personally. But again, just be mindful that it can have other interactions.
So aside from supplements?
Aside from supplements, try not to pull away from activity, but you may need to adapt what you're doing depending on what it's causing. So for example, if you know that running's bad for you, you may need to look at cycling, which is a little less stressful on the knees. There's lots of evidence out there for doing specific strength programs for around the joint. Helps to stabilise the joint, and if you're not getting as much translation of the joint, you're not going to get as much pain. So targeted strength program, yes, supplements might help a little bit, and adapting the load that you're putting through it. It's probably not something I can tell you. I can't give you a full-on program to do right here and now, but there would be things that you can do for your joint, and through assessing it would be able to tell you that. Yeah. Anything else?
Just from a footy club point of view, so you're saying really we shouldn't be putting ice on players unless they can't handle the pain?
Yes. It can, so the compression is still helpful, as we've learnt from Peace and Love, but there isn't a lot of evidence for it, no. Okay.
Can I clarify something there? I think your perspective is very interesting, the long-term recovery of the joint itself.
Yeah.
I think that if you do have a major trauma on the foot, or any trauma, I think the benefit of a full compression and a hot contact, for example, is that it will reduce bleeding, reduce bruising, and it will reduce the possibility of blood injury into the joint space and the subcutaneous tissue. So if I had someone come to me that had injury in the footy field, I would compress it, I would strap it up. But I don't think it probably impact the joint long term.
No.
What you're after. But it will reduce bleeding for sure.
There's some, I think, without going back and forth here, the body has natural processes to follow through. There are things that you can do to try and minimise those processes getting out of control. But we still do need to let those processes occur, is probably the answer to that. Yeah.
Conversely, what about heat packs afterwards?
So heat, you wouldn't want to do, normally they say up to 72 hours. You don't want to be using it in that period because you are going to stimulate more vascularisation or more blood flow to the area. So after 72 hours, I'd probably be even safer than that and leave it longer because you don't want increasing blood flow into that, swelling into that area even more, okay? Yeah. Cool. All right.
Thank you very much, Nigel. That was really